Good morning, good afternoon, or good evening, depends on where you're logging on. Welcome to the October issue of the Australasian Pleural Seminars. Today, we're very delighted to have Professor Jenette Creaney from University of Western Australia to come and talk about biomarkers of pleural diseases and mesothelioma. Jenette is a biomarker discovery scientist and was famous for establishing mesothelin as the first FDA-approved biomarker for mesothelioma. She's currently the scientific director of the National Centre for Asbestos-related Diseases in Perth, Australia. So she's going to come and talk to us about biomarkers for pleural diseases today. So just to remind the audience, please put all your questions as we go along on chat so that we can talk about them afterwards. Thank you, Jenette.
Thank you, Gary. So yes, thank you for the invitation to speak. And yes, today I was just going to speak about biomarkers for pleural diseases with a particular emphasis on their clinical utility. And as my research is mainly focused on mesothelioma, I was going to highlight some of the more mesothelioma-specific things. So just for Australian context, we see roughly 60,000 pleural disease cases a year. And again, in context, about 700, so about 1% of them would be due or related to mesothelioma. So, I mean, as you know, pleural effusions can be classed as either two major groups, so the transudates or exudates, but can have a range of causes. And one of my favourite statistics is the whole that there's over 60 known etiologies for a pleural effusion. So what you're probably very familiar with are flow diagrams like this when it comes to diagnosing the cause of a pleural effusion. So this one just was recently published this year and does a nice logical process. So in clinical practice, when we see a pleural effusion, it's likely that given a very good history and a clinical picture, that sometimes that's enough to be able to make a diagnostic decision, and you can treat empirically straight away. But, sometimes more nuanced approach is needed, and that's when we can start looking at the characteristics of the effusion and do, to start with, a pleural fluid analysis, which can consist of, biochemistry, differential cell counts, looking to see if something grows, and a cytological review. So I didn't realise it was 50 years ago. It's probably closer to getting on a bit more, that Light's criteria was established as a way to distinguish between transudates and exudates. So the good thing about this is a very simple and cheap test, and just looking at the LDH and protein levels to try and distinguish an exudate from a transudate. The test has good specificity, sensitivity for ruling in exudates, but is less specificity of around 72%. So that means that although it's stood the test of time, there are still additional things that we could look at to see what the cause of an effusion was. And again, there are, in this simple looking at the pleural fluid, there are some clues. For example, if there's a lot of lymphocytes, you could think about a chronic process like TB or lymphoma or sarcoidosis. If there's lots of eosinophils, It could be a flag for blood or air in the pleural space. So pneumothorax, hemothorax, low pH kind of implies infection and empyema and whatnot. So, but all these characteristics are not definitive diagnostic tools, but rather give an indication of what could be the underlying cause. And there are plenty of examples in the literature where these guidelines don't actually apply. And I think the main instance is when we're looking at those cases, which is estimated to be up to 30% of cases where there could be multiple causes for the underlying effusion, particularly if you're looking at cardiac disease and an infection situation. So going more on to a disease-specific biomarker, I was just going to highlight these two well-established examples. I always pronounce this badly. So NT-proBNP, if there's high levels, is very indicative of congestive heart failure. And again, in areas where tuberculosis is prevalent, high levels of ADA are very indicative of tuberculosis effusion. And the reason is that these are reflecting the underlying pathophysiological processes that are going on. For example, indicating that there's stress in the heart wall or a lot of immune cell activation for tuberculosis effusion, and these markers are elevated. So when we're but again, just noting that these are useful tools, but not diagnostic. So they're improving our confidence in the causality. So when we're faced with a malignant effusion, cytology is the gold standard, but the problem is that it's not always conclusive, and depending on the setting, it's estimated about 60% of cases won't be possible to diagnose by cytology. So these particular cases are where we need additional tools for looking at tumour biomarkers. And there's a panel of classical malignant effusion biomarkers that have been used extensively, 30 years, and you're hopefully familiar with these, like carcinoma embryonic antigen, the cancer antigen series, and for example, CA125 is commonly elevated in ovarian cancer. So these markers, including mesothelin, are elevated in cancer and in a particular cancer, but they're not necessarily specific for that tumour type. So looking at mesothelin, which Gary said was the work we had particularly focused on, mesothelin is also a glycoprotein that is made by tumour cells, and that's the reason that they're good cancer biomarkers. So this picture just shows you a nice clump of tumour cells expressing in the brown stain lots of mesothelin in a background of immune cells and elevated levels of mesothelin. So I was just going to show you some of our data. So this shows levels of effusion mesothelin on the y-axis and different disease groups on the x-axis. So we were able to show that 2/3 of mesothelioma cases in the effusion, you have elevated mesothelin. And as I was trying to articulate, that this can also be elevated in other cancers, and about 10% of other cancers will shed mesothelin into the effusion. So whilst it's not diagnostic of mesothelioma, it's indicative of cancer, particularly when we look at this cohort and we see that only less than 1% of the benign effusions we see a false positive increased mesothelin level. So I just wanted to drill down a tiny bit into the mesothelin in the mesothelioma effusions. So what we were really interested to see was that in this data presented here, we've got the time from diagnosis being time 0, that mesothelin levels were also able to be detected way earlier, so over 18 months earlier than it was possible to do a pathological diagnosis of mesothelioma. So the value of biomarkers aren't so much that they are diagnostic, but that they give you an indication that something is going on and you should probably pursue more vigorous investigations to see if these cancer biomarkers are elevated, if you can find malignancy. So moving on, the next wave of biomarker research is kind of looking at the effusion as a liquid biopsy. So like they say with blood as a liquid biopsy, because it can carry the tumour DNA and RNA and give signals of the epigenomic events happening. So this is very much still in a research space, but there's a lot of interest here. So I was just going to present an example that I found looking at circulating tumour DNA. So this recent publication, they did a prospective study and they looked at the lung cancer cases. And they were able to show that if you looked at the circulating tumour DNA within the pleural effusion, you could detect actionable mutations in 45 out of the 50 cases they looked at. So most of these were in EGFR, which is the circle. So even though there are still problems with this kind of test, the cost, the accessibility, and a need to standardise, this obviously has the real potential to guide treatment, especially in cases where it might not be possible to do a biopsy. And given the current interest and the fact that first-line immunotherapy using checkpoint blockade is common in many malignancies, there's also growing interest in looking at profiling the immune cells within the pleural effusion. So what we have done in a recent study is we've looked at the pleural effusion samples and used flow cytometry and a single cell RNA sequencing to characterise the immune component in a bit more detail. And so on the left, this is just showing you the different clusters of different immune cells present in a panel of effusions. And the cells I want to particularly point out are on the right. The orange and purple cells are exhausted T cells, either stem cells or terminally exhausted T cells. So these cells have been getting an awful lot of interest lately because that they're believed to be the stem cells are believed to be the ones that are actually functional and activated by the immune checkpoint inhibitors. So in our cohort that we looked at here, it was a retrospective cohort, and not many people had actually received immune checkpoint inhibitors. But what we could show in the group was that a higher proportion of these TX stem cells, the orange ones, in the pleural fluid was significantly associated with better survival in a multivariate analysis, taking into account whatever treatment they had and histology, etc. So we were able to show this both in a cohort of obviously stage 4 lung cancer cases because they had effusions, and a cohort of mesothelioma cases. So what I'm hopefully showing is that what's interesting is that the effusions aren't just giving us diagnostic information, they may be able to help us guide treatment choices and prognosis. So just to summarize, and I've got no idea what the time is, pleural effusions are common and can have diverse causes, and that routine testing can give us important information, but it's a bit limited in terms of a diagnosticness, but the information and the biomarkers add value, and particularly when we're looking at difficult cases, the biomarkers can point you in a direction for further investigation. So probably not a new concept to this audience that pleural fluid isn't just something that can be should be thrown away when you're draining it to relieve patient discomfort, but could be a valuable source for diagnostic as well as therapeutic information. So I just wanted to quickly acknowledge my collaborators and team, particularly Professor Lee, who we work closely with, and our funding bodies. Thank you.
Thank you, Jenette.
Did I go too fast?
That's a very good summary of what the state of play. Can we just, from a more practical point of view for the audience, I think a lot of places in Australasia at the moment still find it hard to go and measure mesothelin. And I think getting the test kits is getting actually increasingly more difficult. Any advice?
So I don't actually have any advice. I do know that the company has actually made a new version of the kit, but I still don't think that there's economic, I don't know, drive for the pathology labs who are, driven by economic things to source it, because it's not going to be funded by the government subsidies.
Right. I think one of the ways to get around it is to request it more, and it would drive down the prices. Can we ask you, a lot of clinicians are very keen to run projects on biomarkers, and we have seen quite a few high-profile mesothelioma biomarker papers in the New England Journal in the last few years that could not be reproduced by other groups. And can you have some advice why projects on biomarkers in pleural diseases, especially mesothelioma, most likely fail, so that we can learn from that?
So I think with biomarker discovery studies, the whole issue is that most biomarker discovery studies are done with a case control cohort, and it's not so much the cases which are important, it's the controls. So if you think of the clinical situation, you're able to, almost intuitively say, this is heart failure. So there's no need to, whereas the clinical problem is distinguishing some of these complex factorial effusions. So if you have a very clean, clear control cohort, it's going to artificially improve the specificity of any biomarkers you report.
Okay. Any advice on, if tissue is absolutely important when you're looking for biomarkers in pleural diseases? That's always the argument: is the fluid enough, or should it all be done on pleural biopsies?
Well, I suspect it's the caveats that are always raised. Some effusion doesn't have many cells or or is very dilute. But then again, taking a biopsy is also a sampling error prone issue. So, whilst there are pros and cons, there are pros and cons both to looking at the effusion and looking at the tissue itself. And I think clinically, the big problem is, especially in Australia, where we have a aging population, many of the patients are a bit more delicate with more comorbidities, and it's not necessarily good to have invasive procedures.
Yeah, I think that's right. We have never seen so many 90-something-year-old mesothelioma patients in our services until recently. So I think that is going to be a big issue. Any things from the audience? I don't seem to be able to see the chat. So if anyone has got any questions, please just add to the chat room. I'm going to ask another question, which is how much volume of fluid do you usually want?
And how long is a piece of string? Because effusions are so diverse, there's probably no specific answer. When we're talking like soluble biomarkers, like the glycoproteins and classical biomarkers, yes, 50 mils of effusion will probably be more than sufficient. Looking at the circulating DNA, and particularly looking at the immune cell profiling, that's when it's necessary to have the more is better, which then becomes a toss-up between what is required diagnostically. So the fear I have about the study, we were looking at the immune cell characteristics as a prognostic marker, is that the cohort is a little bit skewed because we've only been able to select those who have enough cells to actually do the analysis. So there might be some fundamental reason for effusions having more cells that could affect prognosis as well. So it's, yeah.
So I think from the clinicians contributing to samples for scientists' point of view, some of the hurdles is, other than volume, do we need, to put it on ice? Do we need refrigeration? Do we need processing fairly urgently? And do you think the money lies in the cells or the fluid, or you need to have both? In which case, then, what kind of preservance would you like to have? It seems like in the old days we tried to put them into every single color tubes so that you got EDTA, heparin, and all kinds of things, and then the scientists will come and say you have put it in the wrong tubes, and then we can't do it. It is quite frustrating for clinicians. So what's your advice?
So probably talk to your team, but we found that, you know, because the effusions are all, you know, milieu naturally, that if it's not going to change too much of the dynamics to have them just as they come rather than in preservative if they can be processed in a relatively quick time frame. The cells are normally at 37 degrees in your body, so it's not a great shock for them to be sitting at room temperature for a short while.
Okay, good. So I think we're right on 1:30, so we're just going to stop here. I'd like to thank Jenette for excellent talk and interaction. I'd like to thank the audience for joining, and we look forward to seeing you in November. So in November, we're going to talk about practical guides or practical tips for doctors in managing pleural drains. And we'll have Chloe Charlesworth, who is our nurse specialist, to talk about it. And we're hoping to have a panel of the leading pleural nurses from around the country to share some of their expertise as well. So I look forward to seeing you in November. Thank you.
Thank you.